Good evening, everyone, and thank you for joining us. Welcome to our hand pain conditions webinar. I'm Katie, one of the members of the marketing team, and I'm delighted to be joined by Mr James Nicholl, who's one of our consultant orthopaedic surgeons here at the Horder Centre. Mr Nicholl treats the full spectrum of hand and wrist problems, including total joint replacements for the finger joints and thumb base, arthroscopy of the wrist, as well as common conditions such as carpal tunnel syndrome, Dupuytren's contracture, thumb arthritis and tennis elbow, many of which he will be discussing this evening. Before I hand over to Mr Nicholl and his presentation, I just want to remind you that this is a live recorded event and the recording will be emailed to you. Please be aware that we won't be able to respond to hands directly, but do drop any questions that you have into the Q&A box and we'll ensure to address them during our segment later in the webinar. If you do wish to remain anonymous, please ensure that you click that button when you submit the question. So once again, thank you all for joining us and please welcome Mr James Nicholl.
Thank you very much, Katie. Thank you very much, everyone, for attending. As Katie has said, I'm an orthopaedic surgeon specialising in hand and wrist surgery, and I'm going to talk to you today about these common conditions which affect the hand and wrist. So I'm going to start with carpal tunnel syndrome. I'll talk about trigger finger, something called Dupuytren's contracture, and then hand arthritis, and cover just some of the joints in the hand that are affected, but there are all bits of the hand can be affected by osteoarthritis. So if I start with carpal tunnel syndrome, this is the most common condition that we treat as hand surgeons. And the cause of it is that the nerve that supplies feeling to the fingers runs through a space on the front of the wrist. There's a crescent of bones behind and a ligament across the top, with the nerve and some tendons running in the space between. And this ligament thickens, so effectively the roof of the carpal tunnel drops down. There's less space for the nerve, and initially this will irritate the nerve and this will cause pins and needles or tingling, and often it's the thumb, the index finger and the middle finger that people notice are worst affected, but some patients will say the whole hand feels as though it's been involved. And situations where it can occur can be when you're driving, and people say that they're driving and they have to take their hand off the steering wheel and shake it because it's gone numb or getting pins and needles. If you're sitting reading, holding a book or a newspaper, then the hand can go numb. People holding their phone. And it's often a problem at night, and it can be miserable at night, waking people up frequently with a painful pins and needles. And that pain can sometimes even spread up the whole arm. To get rid of the feeling, patients describe, if they're in bed, hanging their hand over the side of the bed, shaking the hand, and then that usually brings it back to life. If the pressure on the nerve becomes more severe, then rather than just irritating the nerve, this can stop the nerve from working normally, so that the sensation from the fingers isn't felt. The fingers become numb. And when this occurs, people can drop things because you haven't got that feedback to know that you're holding something correctly, and doing fiddly things with your fingers. So often people will say that they can't do up their buttons because they just haven't got that dexterity to do it. And other symptoms that aren't universal with carpal tunnel, patients can have a swollen feeling in their fingers. The fingers can feel stiff and they can feel cold. There are some conditions that make carpal tunnel syndrome more likely. People with diabetes are more likely to have it if they've got an underactive thyroid, even if they're taking thyroxine replacement treatment. It's a bit more common in people with rheumatoid arthritis, and it's a condition that can occur in pregnancy, often will occur during the third trimester. And if that does occur, then we just try and manage things very conservatively, because once the baby's been born, then the carpal tunnel symptoms will usually resolve. Not always, but that's often the case. I see it quite often after people have had a wrist fracture. I think that with perhaps if there's a bit of deformity of the wrist, or if there's some swelling from the fracture, then this can precipitate carpal tunnel syndrome. And some people, there's a family history. I've certainly seen people say, "Oh, my sister's got it, my mother's got it." And I say sister and mother because it is more common in women than it is in men. What can you do about it? The first line treatment, and this will often be what the general practitioners will recommend, is to support the wrist with a splint, like the one shown in the photograph on the right. So that's got a metal strip in the front and then the material with Velcro straps at the back, and it stops the wrist from bending forward. And I find it most beneficial for patients if they wear it at night. If you're getting a bad night's sleep because you're getting this painful pins and needles in the hand, wearing the splint at night can be helpful. Beyond that, the next thing that could be worth trying is a steroid, a cortisone injection into the carpal tunnel. Some of the GPs and specialist physiotherapists will do these injections. It often works well, but may well only give temporary relief. Now, whether that's a few weeks or a few months or sometimes longer is variable, but the evidence for it curing the problem isn't great. And the situation where I would counsel against having a steroid injection is if there's a permanent numbness in the finger. So if the carpal tunnel has developed to the severity that there's a permanent change in the sensation in the fingers, then the steroid injection, it may get rid of the pain and help with sleep, for example, but the numbness of the fingers won't recover. And then the third option for managing carpal tunnel is an operation. And it's the operation I do more frequently than anything else. It's very, very common, as I've already said. And my indications for offering surgery for carpal tunnel syndrome are that if people have tried the first two more conservative measures, so they've been using a splint for a while and that's not addressing the problem, or they've had a cortisone injection which worked, but then the symptoms have recurred, then at that point, I think offering surgery is appropriate. As I've just said, if there's a permanent loss of feeling in the fingers, so the sensation never recovers to normal, then if the patient wants help with that, then the surgical release is the only way that is likely to reverse that. And similarly, that if the nerve isn't functioning normally, that you lose feeling in the fingers, the muscle can also waste away and become weak. And this is, so you've got your thumb there, this is the fleshy muscle in the palm. And here, this muscle has wasted away. And again, once the carpal tunnel syndrome is bad enough to have caused that, then recovery becomes less predictable. And then some patients, just the symptoms are really bad. They want the definitive treatment. And then if they, explain to them what's involved, they decide the operation's right for them, then I'm happy to do it. To have carpal tunnel surgery, I do almost all of them under a local anaesthetic. So rather like the dentist can numb your teeth with an injection, I do the same into the area where we're going to operate. And that's the only unpleasant bit of the whole procedure. That I tell all my patients that is going to sting for a few seconds before it goes numb. No one likes it, but it's usually tolerated. During operation, I blow up a tourniquet, which is a blood pressure cuff around the upper arm, and that's normally tight around the upper arm for about 4 minutes. And then I divide this fibrous band over the nerve, which is called the flexor retinaculum. And in the photograph on the right, where my arrow is there, Katie, is that arrow showing on the screen, on the pictures?
Yes, we can see that.
So I've cut through it there. That's the nerve underneath, and that cut through the retinaculum would extend over the full length of the carpal tunnel. I then sew up the skin with some nylon stitches, and RO stands for removal of sutures. That needs to be done 12 days after the operation, and mostly that's done by the nurse in the GP's practice for us. Often with patients who've come to me with carpal tunnel syndrome, they want to know, how is this going to affect them afterwards? Because there are all sorts of reputations, which I think, see, some people are told you can't use your hand, you can't drive for 6 weeks. In my opinion, this sums up the recovery period afterwards. So I put a big padded bandage around the wrist, which is removed after 48 hours. And even with that on, it's essential that patients move their fingers as much as they can, and they can use their hand for simple, light things. After that bandage is taken off, they then have a dressing over the wound. I like it to be kept dry for 12 days until the stitches come out. And during that time, using the hand to the extent that people find comfortable. So often driving within a few days, some people, a little bit longer. If someone does a lot of clerical work, so they're on a typing all day, then usually they're back working normally after 2 to 3 weeks. Carpal tunnel syndrome seems quite common in clinical staff, so people who work in healthcare, and they're normally back working after about 3 weeks. For heavy manual work and sport, then that might be slightly longer to be back at work. But of course, every patient is different. How quickly they recover varies. But that, I think, is a fairly sort of typical recovery picture for carpal tunnel surgery. All operations carry some risks. So they're listed there. The picture on the right is just another intraoperative picture. So it shows you where the incision is and roughly how big it is to do a carpal tunnel release. The risks, you can read them, but the scar can be tender. Pillar pain, some people get as a bit of aching in these muscles either side of the scar, which normally will settle if it does occur fairly quickly. Any surgery, risk of infection, which is why I like it kept clean and dry. With nerve injury, some people are aware of a numb patch around the scar, and there's small risk, and that's why having the surgery done by someone who is properly trained and experienced in doing carpal tunnel surgery is that there are anatomical variants. It probably doesn't show particularly well, but there's a nerve coming off here, which is an abnormal position of this nerve, and this supplies these muscles in the palm. And if you weren't aware that you can have abnormal anatomy, if you weren't looking out for it, then you could damage that nerve during the operation. Then a condition called complex regional pain syndrome. This is about a 1 or 2% risk with carpal tunnel surgery. And this is a nasty condition where the fingers get sweaty, stiff, swollen, and painful. If the fingers were completely numb before the operation, then the recovery can take many months. And with carpal tunnel, as with all operations, I warn my patients that there's never a 100% guarantee that the surgery will be successful. But mostly with carpal tunnel release, my patients seem to be very pleased. If you're getting sleep disturbance, then even the first night after the operation, there's normally a good night's sleep. I'm now going to move on to the next condition, trigger finger. And this is the finger clicks. So as it bends forward into the position as shown on the photograph on the right, it gets stuck there. And either just with a bit of effort, it can go straight and there's a bit of a jump as it goes, or sometimes people have to pull it straight with the other hand. It can be quite painful to untrigger it, to unstick it, and some people get discomfort in the palm. So down where this little lump that I'm talking about, this nodule in the flexor tendon, is down in here. This is where the catching occurs. People might think that it's coming from the joint. It gives that sensation, but the pathology is down here. For this, we definitely would recommend a cortisone injection as the first line treatment. This is something, again, that some of the GPs will do, some of the specialist physios will do. And the success rate of this curing the problem long term is pretty good. I did a personal audit, and 2 out of 3 of the patients didn't need anything further doing to it. And from other studies that have been reported in the literature, the percentages vary from, as you can read there, 47% at 6 months up to even 87% at 42 months. If the injection works well for a number of months and the condition comes back, then it's certainly worth repeating it a second time. After that, then I would offer patients surgery, or if the injection only works briefly, then the patient might well say, well, it only gave me a few weeks relief. Can't you do anything else? Because it can affect more than one finger. So if someone said I had an injection to treat my other hand a couple of years ago and it didn't work and I ended up having an operation, I don't want to go through the injection route, just get on and operate on it, then I think that's a reasonable decision. And the surgery, not dissimilar to, in order of magnitude, to a carpal tunnel operation. So I have my patients wide awake, numb the area in the palm that I indicated on the previous photograph, about a centimetre incision, and then that exposes. This is where the tendon runs. This is the tight bit where the nodule is catching. And then in this second photograph, I've cut through longitudinally through that fibrous band to expose the tendon, which then runs freely. The recovery from that is similar to a carpal tunnel, big bandage for 48 hours, and then keeping the wound covered and dry with usually 3 little stitches in the skin to come out after about 12 days. The next condition I'm going to talk about is called Dupuytren's contracture. And this again causes a bent finger, but it isn't one that can be pushed straight, and it's a gradual thing. The condition starts usually with some lumps in the palm. These then spread and become longitudinal cords, and then over time will gradually bend the finger down. And that photograph shows a sort of averagely bad one. However hard you press down on that finger, it wouldn't go flat. Some patients will have lumps in the palm for years before they develop a contracture. Others will tell me that they first noticed the lumps, a handful of months previously, and then it's fairly rapidly progressed down. This patient has left it too late. So that's the same problem, but the fingers, as you can see, the ring and little fingers there have got a severe contracture. And then that becomes much more difficult to treat. It's not usually a painful condition, and it develops gradually. So I think that's why people don't necessarily go for treatment straight away. Initially, where the lumps are, it may be a bit tender. So if you're gripping things and you've got pressure against the lumps, then it can be a bit uncomfortable. But once the fingers start bending down, then that discomfort does usually settle. There's often a family history, and it's very much a sort of Northern European gene pool who get it. So it is known as the Viking disease. It sort of came across with the Vikings in the first millennium whenever they invaded England, and it's common up in Scotland, in Northern Ireland, up in the northeast, but much as you go down towards the Mediterranean, into Africa, into Asia, much less common. Other risk factors for it, again, more common in people with diabetes, with alcoholic liver disease. Some drugs are thought to cause it, and mechanical factors, the jury's out on this one. When I was a medical student, we were all taught that it was people who used pneumatic drills for digging up the roads were prone to get it. There's been a study that shows it's more common in rock climbers. I sometimes see it develops in people after they've had a wrist fracture. So their wrist's treated in a plaster cast, the plaster comes off and they develop these lumps in the palm. But there's no strong epidemiological evidence that these mechanical factors cause it. And like a lot of things still in medicine, we don't have all the answers yet. With the lumps in the palm and the contracture of the fingers, some people get tender lumps on the back of their knuckles, which are called Garrod's pads. It can affect the soles of the feet, what's called plantar fibromatosis, and this is more common where people have got a strong family history and perhaps develop their Dupuytren's at a younger age, and also can be associated with something called Peyronie's disease, where you get the cords in the penis, and you can get a curvature of the penis associated with the Dupuytrens. It's not something that when it first appears that you need to rush off and get it treated. And the time to treat it is when you can't put your hand down flat. And that used to be called the tabletop test. So you try and put your palm down, and if the palm all along can be brought into contact with the top of the table, great. But if there's a hollow that your finger is so bent that you can't get the hand down flat, then that is the time to consider treatment. The NHS is a great one for measuring things, and the criteria that they recommend that Dupuytren's is treated is if the MCP joint, so that's the first knuckle nearest the wrist, is bent to 30 degrees, or the middle knuckle in the fingers, what's called the proximal interphalangeal joint, the PIP joint, is bent, then that is the time to consider treatment. And from the previous photographs I've showed, the first one is when I like to see people, not like the last one with that very, very severe contracture. The reason that we don't operate on it straight away, which is one of the treatment options, is that after surgery it can come back, and that's time dependent. So it's much better to wait until it has got to the degrees that I've described there to treat it, rather than when the lumps first appear. To try and prevent it from developing, there is some evidence, but it's not particularly strong, that giving radiotherapy to the palm may delay its progression. I referred over my entire career only 1 or 2 patients for this. My personal, I think I'd have to call it a prejudice, but we're all allowed prejudices, would be I'm not sure I would want radiotherapy to my palm for a benign condition, but it is available as an option. There's a man over in Guildford who does it. And then there's a drug that has been developed by the Oxford group, and they've done the first phase of a trial, which looks promising, but it's not on the market yet, and there'll be further studies and results have to be looked at, etc. But it may be over the coming years that a treatment that prevents it developing becomes available, and that would then make the treatment options redundant, possibly. But to go through what we do currently, if the contracture is just in the palm, but the PIP joint is still straight, or it is an option for, I suppose, any Dupuytren, something called a needle fasciotomy. So a bit of local anaesthetic, and just with the needle through the skin, I scratch away through the cord to divide it, and can usually get the finger fairly straight. The recurrence instance is reasonably high, and you still have the lumps. Similarly, if it's just in the palm, you can just cut out a little segment of the cord. So again, under local anaesthetic, takes a matter of minutes, but you still have the majority of the cord, and the recurrence rate is reasonably high. The standard treatment that I would offer for most people with Dupuytren's is an operation where we cut out the cord of Dupuytren's. So the photograph on the left is towards the start of the operation. I've opened up the skin. This is the cord of Dupuytren's, this fibrous tissue that has contracted and pulled the finger down. I've cut out that cord, so it's not the tendon, it's a buildup of abnormal tissue. And by removing that fibrous cord, the tether that's been pulling the finger down, it comes out straight. The recovery for that, I normally start with my patients with a slab of plaster of Paris on the front of the hand. That's removed after a few days, and we get our hand therapists to make a removable splint, which I ask my patients to wear at night for 2 to 3 months. And they supervise exercises to get the grip going. There are stitches in for a couple of weeks, and initially it's a bit stiff and swollen and scabby. So it is, there's a bit of recovery involved, but the hope is that the finger's straight, the scar is just a fine white line, and full grip and function recovers after about a month or so. So back doing all normal activities after about a month. Moving on, hand and wrist arthritis can affect any of the joints in the hand. Often it's spontaneous. There may be a family history. If a joint gets damaged with an injury, if there's a fracture that involves the joint, then that could lead on to arthritis. But often it's just bad luck. And as I go through, I use abbreviations, and just for the anatomy, this one at the tip is called the distal interphalangeal joint. This next one here is the proximal interphalangeal joint. And this one is the metacarpophalangeal joint. So the MCPJ, PIPJ, and DIPJ. And in the thumb, you've not got two joints. You've only got the single, what's called the interphalangeal joint in the thumb. And then the last bit I'm going to talk about is arthritis at the base of the thumb. So is the joint down here where the thumb meets the wrist. Those are what I'm going to cover now, just because of the restrictions of time. But wrist arthritis is common. I see a lot of patients with wrist arthritis, either occurring spontaneously or following a previous injury which has damaged bones or ligaments, and it can affect these other joints in the middle of the hand as well, what's called the carpal metacarpal joints. But we'll start with any of these joints that are affected. And initially, with any of these things, surgery is the last resort. So to start with, taking simple painkillers when it's bad, doing things in a slightly different way. For example, if it's the base of the thumb which is painful, things like opening or a lid or a bottle top can be very difficult and painful. Getting one of those devices that grips the lid will make that easier. If there's something that you're doing that makes the arthritis worse, then common sense says, well, do something different. Splints can help, particularly there's a wrap that supports the base of the thumb can be quite helpful. If the pains are bad at night, then holding the joint still with a splint at night can help. And for wrists, the same splint that I showed you for the carpal tunnel syndrome, so what's called a Futura wrist splint, which supports the wrist, keeps it still, can be very helpful. Most of the joints, if on the X-ray they're not too bad, and there's still reasonable movement, then to get rid of the pain, a steroid or cortisone injection, they're the same, they're just different words for the same thing, can be quite helpful. How well they work and how long they work for is variable and unpredictable, but it's relatively straightforward and low risk. Some of the joints, because they're very small, we do with either X-ray or ultrasound guidance so that we can guide the needle right, so we know it's in the right place, and it's just a more accurate way of doing it. And then for almost any of the joints affected by arthritis, if those more conservative measures have been unsuccessful and the patient's in terrible pain and they need something more doing, then there are operations that can be done to help with that. So if we start with the distal interphalangeal joint, so it's this one nearest the tip of the finger, the joint should look like that, nice and smooth, a bit of a gap between the bones, and then as we come to this one, it's all eroded away rather than just the surface wearing away, which occurs in osteoarthritis. This one has developed so severely that the bone is eroding into the other bone. You get splaying of the bone and you get these knobbly bits that you can see around the joint. It's tender if it's pressed, and applying pressure through the finger can be very painful. So if it's an index finger, things like pressing an aerosol can becomes very difficult and painful. Even holding a pen can be bad. The shape of the finger can change. It can start angularly in one direction or another. And for this end joint here, the surgical treatment that we almost always do is to fuse the two bones together. And that's what this picture shows. So you remove what's left of the damaged surfaces, put them together, and then hold them in position. This screw's inserted through the tip of the finger, and then rather like a fracture healing, the two bones knit together. That gets rid of the pain completely, but of course you lose any movement that you had in the joint. For an index finger, that's functionally not too bad. If you're holding a pen or a fork or pressing something, then not being able to curl the tip of that finger in, doesn't have a huge effect. If you go over across to the little finger, clenching a fist and bending that finger in is more functionally an issue. But if the patient says the pain is bad enough that I'm not using that finger anyway, then a fusion like that is good. Very occasionally, rather than doing that, I will put in a little artificial joint, which leaves a little bit of movement. They don't get a full range of movement. Fairly good at getting rid of the pain, but the concern is that the little plastic joint that we use may fail, and it's getting the wound to heal and things can be a challenge. So it's available if someone says, no, I really need to keep some movement in the tip of the finger, but my standard for painful arthritis of that tip joint is to fuse the bones together as shown there. The next joint, the proximal interphalangeal joint, is more important to keep movement there. If that is stiff, then that has a much bigger impact on the function of the hand. When patients first have symptoms, again, initially the treatment is conservative. So it might be massaging the finger with an anti-inflammatory cream, keeping it warm, perhaps using a splint at night. So any non-interventions that are beneficial are definitely worth trying first. I'll then probably try a cortisone injection into the joint, often good at relieving the pain and some swelling for a while. It's not going to cure the arthritis. And if those more conservative measures have failed and the patient says the pain is too much for me to put up with, do something more, then surgery becomes an option. Arthrodesis is fusing the bones together. So you can fuse that joint together so that the pain goes, but there's no movement. But that does have a more significant impact on the function of the hand. And I'd say the vast majority of patients who I'm operating on for painful arthritis in this joint elect to have a joint replacement. The photograph, the X-ray on the right shows the white is a metal implant and it's got a plastic bearing between the two. And I used that implant for a while. Because they're not that frequently used, the manufacturers are should we say difficult with these. So this implant, which I thought was good, I enjoyed using it, and I think it worked well for my patients, has been withdrawn from the market. And the one that I use currently, and is really only, there's one other kind on the market, is a little plastic hinge. Again, works fairly well at getting rid of the pain. How much movement we achieve is quite unpredictable, but on average, I'd say the range of movement is going to be about the same after the operation as it was before the operation. So it's not something to do to improve movement, but it can be quite good at getting rid of the pain. Arthritis at the base of the thumb is one of the most common parts of the body to have arthritis. And it's this joint, what's called the saddle-shaped joint, at the base of the thumb. This bone is called the trapezium, and this is called the metacarpal. And the should, rather like you've got a gap between the bones there, it's worn away. You've got no gap between the bones, and then you get these spurs of bones called osteophytes. And I think it's so common because as humans, we put huge pressure through our thumbs, and not just these days for texting and all that. I think for everything, even going back to cavemen making flint tools, the thumb is really important for the function of the hand. And I don't think the thickness of the cartilage has evolved, and we're talking, over millions of years, not the last 20 years, to keep up with the demands that humans put on their thumb. So it's incredibly common. I mean, there was a study that looked at x-rays of postmenopausal women, and about a third had evidence of arthritis in this joint, but of those only a third had symptoms. But that's still 1 in 9 postmenopausal women in this study had some pain from arthritis in this joint. The pain is often aggravated by either pinching between the thumb and index finger, so pegging out, washing it, or using a key, and gripping movements. So trying to remove the lid from a jam jar or a bottle top is often painful, and because it's painful, the hand becomes weak. And I had a patient actually in my clinic here this afternoon who had arthritis in his joint, and he said, it's embarrassing. I have to give my wife the jam jars to open now. I can't do it because my thumb is so sore. As the arthritis progresses, then you can get rest pain as well. And if it's severe, it can disturb people's sleep. Writing, because you have to apply pressure with your thumb to hold the pen, if it's your dominant hand, will become painful. And examining patients, there's often swelling there. Pressing on the joint is very tender. And then if you give it a bit of a wiggle, there's a sort of painful crunching sensation where you've got the bone surfaces rubbing on each other. And the diagnosis is, once you're suspicious of it clinically, which is a fairly straightforward diagnosis to make, then the X-ray gives you the answer. It shows you that you've got these features of osteoarthritis in that joint. The options for treating it, a splint can be quite helpful. So if you say, well, it only bothers me when, for example, I'm doing my gardening, then getting a support for the thumb to wear when you're doing your gardening is a sensible way to manage it. Injections into the joint are more likely to work if the arthritis isn't too terrible on the X-ray. So the more advanced, if you've got bone-on-bone arthritis, then an injection is unlikely to do much. If it's more that the lining's inflamed and swollen, causing the pain, then a cortisone, a steroid injection into the joint can be helpful. That photograph is just a picture of me injecting it. So it can be done just by feeling the joint space and guiding the needle in. But more often than not, I'll either ask that to be done under ultrasound guidance, so you can see the joint, you can see the needle going into it, or I do quite a lot myself, just using an X-ray machine. So you can see the joint space, you can see the needle, and then you know that you're doing the injection into exactly where you want it to go. And if those more conservative options fail and someone's getting terrible pain and they say, sort me out, then surgically, there's an operation called trapeziectomy. And this is one that has been around for a long time. It involves removing the entire bone called the trapezium at the base of the thumb. And I come to that one. So this is an X-ray where someone's had a trapeziectomy. That bone should be sitting in the gap there. This is an X-ray taken after the trapezium had been removed. So if we go back to that one, it's this bone here has been taken out. What I do is put my patients in a plaster cast for 4 weeks, and that holds the thumb in position, and then this gap from where the bone has been removed fills in with scar tissue. So you essentially end up with a lump of gristle that allows the thumb to move, but acts as a spacer between the bones. And the thing I particularly like about this as an operation is when I'm not working at the Horder Centre, I'm a consultant in Tunbridge Wells, and the first person to describe this operation and write it up, and it was in the American Journal of Hand Surgery in the 1940s, was a man called Harvey Jervis, who was a orthopaedic consultant at the Kent and Sussex in Tunbridge Wells. So he's a predecessor of mine in Tunbridge Wells, and he's known throughout the world for the man who described this operation as a trapeziectomy. The downside to it as an operation are that you're in a plaster cast for 4 weeks, and the thumb and the hand can take sometimes a number of months to get as good as it's going to get. So there are, and like all operations, there will be a minority of patients who continue to have symptoms afterwards. So it's not like all operations, it's not perfect. More recently, I started doing joint replacements. So this is like a tiny hip replacement to treat the joint. And this implant has been around for 12 to 15 years. I've been doing it for about 2.5. And what I wanted to see, because there've been all sorts of implants marketed for this over the years, and they've all been quietly withdrawn because they've been a disaster. But with this one, there was a big study from France, and they'd followed up patients for 10 to 12 years, and 95% was still doing well after 10 to 12 years. So I thought, with that track record, that looks as though it works. So I've started doing them, and I've been really, it's not important whether I'm pleased or not. My patients, the majority of my patients, have been really pleased with it. It's only appropriate if this next joint back doesn't have arthritis. So a lot of patients who've got the arthritis of this joint might have it in that one as well. The trapeziectomy will address both, but if it's just this joint, then this is an alternative to the trapeziectomy. Is good. Patients don't go in a plaster cast, they just have a bandage for a couple of days and report that the thumb recovers more quickly and feels more normal. And then I've not shown a photograph of it, but you can fuse the bones together. So if you had someone who was a very young, heavy manual worker, then these first two wouldn't be a good option from them. And you can, rather like we did on the tip of the finger, you can fuse the bones together. So it will get rid of the pain, but you do lose some of the mobility in the thumb. But if it's someone who's got another 30 years to work wielding a pickaxe, then that's probably the best option for them. I could talk about all the other joints affected by hand arthritis for another 4 or 5 hours, but I think that's probably enough from me. So I'll stop there.
Brilliant. Thank you so much for sharing with us, Mr. Nicholl. It's a great presentation, lots to digest. And I can see that some of your insights have already triggered some questions into the Q&A box. So thank you to those who have already submitted questions so far. We'll get through as many as possible. If you haven't had a chance yet, feel free to type your questions into the Q&A box. We'll do our best to address them. Looking at the first one that we have here, my hands and fingers get very stiff and go into a weird shape. I massage them and get back to normal. Why is this happening?
That depends a bit. I mean, stiff hands would then, arthritis will cause the joints to feel stiff. If it's going into weird shape, it can be almost a spasm. So rather like cramp in the leg, you can get cramp in the hand, and it's colloquially well known as writer's cramp, and it's a real thing. So it depends a bit on the situation in which it's occurring. But if it's either writing or it's been reported in concert pianists, so where they're really concentrating on the music and their brains working overtime in their performance, then they sometimes get the fingers go into this spasm, and it really is, it's a cramp. I think a cramp describes it really well. So it may be that if the fingers feel stiff in the morning, that sometimes is a feature of carpal tunnel syndrome, where the fingers haven't been moved overnight, or it can be tendon inflammation. If the tendons aren't gliding, then the fingers can feel stiff. But where the question asker has said they go into weird position, that sort of, to me, sounding is a bit like sort of spasm, cramp-like, so it may be a writer's cramp. Unfortunately, as a hand surgeon, I don't have a solution for that. So I would normally send patients who present with that to a hand therapist for help with exercises, how to use the hands differently to try and compensate for it. But it's not a writer's cramp, there isn't a surgical, or as a hand surgeon, I don't have a solution.
Okay, Moving on to the second question we have here. For years, I've had pain in the saddle joint, top of my thumb/wrist. It has not gone, but my outside wrist has developed quite a sharp pain upon bending movement. Can you explain what is happening, please? Thank you.
On the thumb side of the wrist, there's the tendon that moves the thumb. So over the side of the wrist, you can get an inflammation of that tendon. It's called decurvain tenosynovitis. That's again largely a clinical diagnosis. It's, from examining a patient, I can normally make that diagnosis, and if it is that, then a cortisone injection will often cure the problem for good, a one-off injection. You mentioned in the start of your question the saddle joint, and as I've just the end of my presentation there, talking about arthritis at the base of the thumb being common, or further joints back. So if you've got there, this is where, well, this was the trapeziectomy one, but here in the actual wrist joint, people can get arthritic changes. Often it may be if they've had some trauma in the past. So various explanations. It's obviously difficult with, to just from a one-line question to give you a spot diagnosis, but those would be my thoughts as the possible explanations.
Okay, great, thank you. This is less of a question, more of a relieving hand arthritis pain and way to prevent crooked fingers. I don't know if that maybe covered some of the stuff that you've mentioned already.
Yes, if I had a cure for arthritis, or I could prevent it getting worse, then I think I'd be even richer than Elon Musk. We don't have an answer. There are ways, turmeric and glucosamine to try and manage arthritic problems work well for some people. There's no strong, certainly no evidence that it will reverse arthritic change or that it will necessarily prevent it from progressing. If the finger is tending to deviate away from another finger, then at night, particularly, perhaps holding it with some tape, or you can get the sort of double tubey grips to put over two fingers to just keep it in position. But if this is due to arthritis, I'm afraid it's inevitable, and we can treat the symptoms, but there isn't a cure to reverse the arthritis, unfortunately.
There's a mention here of rheumatoid, which I don't think you perhaps touched on. So the question is, how would you manage a combination of osteoarthritis and rheumatoid arthritis in the wrist?
The rheumatoid will damage the joint and then lead on to secondary osteoarthritis. The management of rheumatoid arthritis has improved massively, even, 5-10 years. When I was doing my training as a hand surgeon, people with severe deformities from rheumatoid arthritis was a big part of the workload. It was either fingers or wrists or whatever, were terrible. The number of patients I'm seeing now with badly damaged hands and wrists from rheumatoid is much less, and that's because the medical treatment is so much better. And most of them are now these sort of immunotherapy things. All the drugs end in MAB, which I think is sort of a monoclonal antibody, and they've all got names, and I struggle to keep up with them. If the rheumatoid over the years has damaged the wrist and it's very painful, then the surgical options, and whether it was from rheumatoid or whether it's from post-trauma or spontaneous osteoarthritis, if it's beyond splints, injections, then surgically I'll often start with a combination of doing a keyhole, so looking into the wrist with a telescope and tidying up the rough bits, and I combine that with a wrist innervation, so removing the nerve fibers which at that level are just taking pain signals from the wrist. So you don't lose feeling in the skin, you don't lose any muscle power, but it reduces the pain signals coming from the wrist. Beyond that, you can fuse either the whole wrist together, which you lose all movement, which if it's severely damaged by rheumatoid might be the only option, or you can fuse some of the bones. So if there's bits that are very worn and generating the pain, then you can fuse those bits. and leave other bits that are less damaged to allow a bit of movement. And then there are wrist replacements available. It's not an operation I do, but I think, I mean, certainly I know there are surgeons over in Ashford, Canterbury, who do wrist replacements, and possibly Brighton as well, and up in London. But so they are on the market, but it's not an operation that I do.
Okay. Again, not so much a question, just a statement here. Somebody said knuckle surgery. Perhaps a bit of an overview of that and potential conditions that can treat.
Yeah, so I showed that little metal, so by the knuckle, the proximal interphalangeal joint, which if you're all very familiar with the terms and the anatomy now, you're experts on that. So starting with injections, the refusions and joint replacements, going back to the metacarpophalangeal joint, so the ones that that are nearest the wrist. So if you were sort of making a fist to punch somebody, the ones that would take the impact. To avoid, so you can put, there are reasonable joint replacements for those, these little plastic hinges, but I'll sometimes, if it's not completely destroyed, do a bit of a surgical tidy up, go into the joint, remove any loose bits, do some drilling into any bare bits of bone to try and create some scar tissue over the surface, and combine that again with a denervation, doing a dissection around the circumference of the joint to disrupt the nerve fibers coming from it, just to disrupt the pain signal coming from the joint. But so there are operations for it. Cortisone injections would be what I would try initially, but if that failed, then those options that I've just said.
Fantastic. And perhaps this person's question has been answered from your presentation, but we'll see. Swollen finger joints and wrist pain causes, is it osteoarthritis or carpal tunnel syndrome?
I think more likely to be arthritis. The carpal tunnel syndrome, classically there'd be the pins and needles or numbness in the fingers. As I said, the fingers may feel a bit swollen. It can be pain going into them and pain going up the arm, which is a nerve pain. But from what you're describing to me, sounds more likely to be either an arthritic problem or possibly a tendon inflammation, because of course the tendons move the joints rather than carpal tunnel.
Okay. And our last question, again, not sure if you've touched on this perhaps in your other answers, but how to deal with pain in thumbs, lack of strength when gripping and lifting items, how to slow down the process?
So again, it may well be this base of thumb osteoarthritis, trying to avoid the things that hurt, but the thumb is 40% of the use of the hand. So if you don't use your thumb, your function of your hand is severely restricted. The supplements, as I've said, work well for some people. Diet and its effect on osteoarthritis, there's lots out there. I don't think there's any strong evidence that any particular diet is beneficial. You know, the whole book's on it about whether you should only eat oranges or never eat apples or whatever it might be. I did talk to a nutritional therapist, and I'm afraid the only bit of the advice that she recommended that I can remember is that red wine was good for arthritic joints, but that possibly says more about me than it does about the recommendation.
Fantastic. That's a great one to finish on. So thank you everyone for submitting those questions, and thank you again, Ms. Nicholl, for providing your expertise on those. So Mr. Nicholl is kindly offering 50% off his initial consultation for those who've attended this evening. So if you would like to book a consultation with him, please get in touch with us via the contacts that you can see on the screens, the telephone number or email, with the reference code that will be emailed to you with the webinar recording. When you do receive the recording of tonight's webinar, you'll also receive a survey link. It's just 3 quick questions for feedback. It's always really helpful to know what is working well, but also areas that we can improve on. So we'd really appreciate hearing from you about how this evening went. But once again, thank you very much for your time and enjoy the rest of your evening.
I'll just say, Katie, thank you very much for organising it, and thank you everybody for attending.
Thank you.
Okay, bye.